Hello, everyone. My name is Samantha Weaver, and I want to welcome you to our live workshop. We are excited to have Patrick McEwen lead us through a workshop specially for the Academy of Applied Myofunctional Sciences. I want to pass it straight to Patrick McEwen, who is a leader in the field of breathing re-education. He has his own personal story of why he began doing this. He's a trainer, educator, prolific writer. He's just come out with his 10th book. And we are thrilled and excited, Patrick, that you can come in, give this workshop for our community.
How are you,
very
Samantha?
Happy to have you.
Thanks very much, Samantha. What I want to talk about over the next 2 hours is to give you practical tips and breathing demonstration of exercises that you can apply for your own health. I also want to tailor the exercises according to your health and your background and different conditions, and to give you the information on that. Nasal breathing is absolutely the foundation of good breathing habits. And when we look at functional breathing, we need to look at functional breathing from a number of different perspectives. It's not just enough to look at breathing from a biochemical point of view. It's not just enough to look at breathing from a biomechanical point of view, but we also need to look at breathing from a coherent point of view or cadence point of view. In other words, breathing has 3 legs to the stool, and that's consisting of biochemistry, biomechanical, and coherent breathing. Now, they are all interlinked, but many of us in our field, including myself for many years, we focus on one without focusing on the other 2. To give you an example, in my background in Buteyko, I focused on biochemistry, but I didn't focus enough on the biomechanics, and I didn't focus on coherent breathing. A yoga instructor may focus more on the biomechanics, but is not necessarily focusing on the biochemistry and is not focusing on coherent breathing. And a heart math instructor, somebody who is working with heart rate variability, they focus on HRV, biofeedback. They focus on coherent breathing, but they don't focus on the biomechanics or the biochemistry. We can't focus on one without focusing on the other 2. And in a nutshell, the biochemistry relates to carbon dioxide pressure in the blood. And the pressure of carbon dioxide in the blood is determined by the pressure of carbon dioxide in the lungs. And the pressure of carbon dioxide in the lungs is determined by the volume of your breathing. And very simply, if you breathe too hard, and all that means is your breathing may be a little bit upper chest and a little bit faster, you lose too much carbon dioxide from the blood through the lungs. And when you lose carbon dioxide, this is causing your blood vessels to constrict. And this causes the bond between red blood cells and oxygen to become stronger. So the harder you breathe, the less oxygen that gets delivered to tissues and organs. For example, it's very common with people who have slightly faster and harder breathing, upper chest breathing, to have cold hands, cold feet, and to have brain fog. So cold hands are not necessarily the sign of a warm heart. Cold hands simply point out that your blood vessels are constricting. So the biochemical point of view is very, very important. And then we look at the biomechanical point of view, and that relates to where are you breathing? Are you breathing upper chest, or are you breathing low? Do you have a good amplitude of the diaphragm breathing muscle? And the importance of this is because the diaphragm is not just for respiration, but your diaphragm breathing muscle also provides another function, and that would be stabilization of the spine. For example, people with lower back pain very often have dysfunctional breathing patterns. And people with dysfunctional breathing typically will have dysfunctional movement. And if you have dysfunctional movement, you increase your risk of injury. So whether this is a normal individual or whether this is an athlete. Now, the nose also plays a role with this because your nose is directly activating a greater amplitude of the diaphragm. And you can check this out for yourself. If you look down at your chest and if you take a breath through your mouth, you will typically see that mouth breathing is activating the upper chest, and nose breathing is more likely to activate the diaphragm. The other aspect with sleep is that the whole airway is linked. The upper airway, which consists of your nose, the nasal cavity, the nasopharynx, which is the nose where the nose meets the throat, the oropharynx, where the mouth meets the throat, the pharynx, and then you have the lower airway. You'll have, say, for example, the trachea, the bronchi, the bronchioles, the alveoli. It's all one airway. And since 2007, researchers have spoken to it as it's a unified airway. So whatever happens up in your nose is going to travel down to your lungs, and whatever happens in your lungs can travel up to your nose. Now, what does this mean for sleep? Well, we know that, the throat stays open during wakefulness. It doesn't collapse. So we don't have an apnea typically as a result of collapse of the upper airways during wakefulness. But obstructive sleep apnea is quite common in adults. And we have to think about the relationship between the upper airway dilator muscles and flow of breathing. We know that when you breathe through your nose, you're more likely to have greater amplitude of the diaphragm. And when you have greater amplitude of the diaphragm, it increases lung volume. And when you have an increased lung volume, the throat is stiffer and less likely to collapse. So your throat is less likely to collapse during sleep when you are breathing through your nose and you are using your diaphragm. We know that when we put on a little bit of weight, typically as we get a bit older, we put weight on the belly. As we put weight on the belly, it impinges on the amplitude of the diaphragm breathing muscle. As we use the diaphragm breathing muscle less, lung volume is reduced and the throat is more liable to collapse. So as I said, it's all one airway. And those set of muscles in the throat, which are designed to help to maintain an open airway, they are also influenced by nose breathing and diaphragmatic breathing. So the biomechanics of breathing is very important because also we have to consider the human lungs. Most of the time as human beings, we are either sitting upright, we are standing, we are upright. And because of gravity, the greatest blood flow in the lungs is in the lower lobes of the lungs. But if you breathe through an open mouth, you are typically bringing more air into the upper regions of the lungs. But the greatest concentration of blood is in the lower regions of the lungs. So mouth breathing is very inefficient, it's very uneconomical, and reduces gas exchange from the lungs into the blood. And this was known back in 1988 when researchers Swift, they looked at patients who were after having jaw surgery, and post-jaw surgery, their jaws were wired shut, which forced them to continuously breathe through the nose. The pressure of oxygen in the blood increased by 10%. So despite that, still, many people are not aware of the importance of nasal breathing versus mouth breathing. And in a very simple way, if we look at the anatomy of the mouth, if you look at the anatomy of the mouth, and I'm just going to share change the speaker view here. When you look at the anatomy of the mouth, in terms of breathing, we realize that the mouth performs 0 functions in terms of the breath. Any air that we take in through that mouth, that air is going to go straight down the throat. Is there any function in the mouth that is provided for breathing? And the answer is no. It is only the nose that performs any functions in terms of breathing. And also we need to consider the amount of space occupied by the nasal cavity in the skull. Most people will consider that their nose is what they see in their face when they look inside them or looking at themselves in the mirror. But in order to realize the extent of the size or the depth of the nasal cavity, if you put your tongue into the roof of your mouth, and if you bring your tongue all the way along the roof of the mouth until you feel the soft palate, you realize then that the roof of the mouth is the floor of the nose, and then you realize just how far back the nose goes back into the skull. And here you have turbinates, and you have some of the functions of the nose in terms of warming air coming in, moistening air coming in, but also trapping the heat and moisture on the way out. You think of the amount of breathing that we do throughout the day. There is an energy expended by the body in preparation of that air as it's drawn into the lungs. And on the breath out, as we breathe out that warm and moist air, the nose serves to recover heat and moisture. So it's more economical to breathe through the nose and we're less likely to get dehydrated. But it's by breathing out through the nose that the nose remains more open. It's thought it is the trapping of heat and moisture on the exhale breath that plays a role in decongesting the nose. Now, We know that, for example, if you breathe in through the nose and out through the mouth, there is a 42% greater water loss breathing out through the mouth. So you can imagine somebody doing physical exercise. You can imagine it in times of COVID, whereby it's believed that the virus is transmitted via water droplets in the air, like an aerosol. If you have a mouth breather, they are emitting a far greater concentration of water particles into the air. So not only is the mouth breather more prone to take in the virus by virtue of larger breathing volume, harder breathing volume, but also they don't have their own natural body's defense in terms of the gas nitric oxide. I'm not saying that nitric oxide in the nose is going to absolutely stop coronavirus. That's not the situation. But whatever chance we have, our first line of defense is breathing in and out through the nose and not through the mouth. Now, the third dimension of breathing then we need to look at is coherent breathing. And this is whereby we can influence the autonomic nervous system by simply changing the respiratory rate to between 4.5 and 6.5 breaths per minute. 6 breaths on average is the optimal rate to stimulate the vagus nerve, to increase the sensitivity of baroreceptors. And it's a combination of this that in turn increases what's called heart rate variability. Now, heart rate variability is where all of the science lies in terms of slow breathing. If you look at any common condition, and if you put it into a search engine, put in that condition along with heart rate variability biofeedback and see if it produces results. And typically, people who are unwell, either emotionally, with anxiety, PTSD, depression, panic disorder, etc., they will have reduced heart rate variability. People who are in high stress have reduced HRV. People who are physically unwell with different conditions such as COPD, asthma, irritable bowel syndrome, fibromyalgia, chronic fatigue, etc., they also have reduced heart rate variability. So heart rate variability is recognized as a clinical measure of stress in the human being. For example, if a couple go through a divorce, or if an individual goes through a divorce, it typically manifests as reduced heart rate variability. If you go to your doctor and you tell your doctor, I'm stressed, that doctor typically will have no way of measuring the degree of stress of that individual, but they could measure it by measuring heart rate variability. Now, heart rate variability biofeedback is just a measure. The real question is, how can you influence it and how can you improve it? So somebody with reduced coherence, and typically what we need is we need the timing between each heartbeat to be random and varied. And there is a link between your breathing and the timing of your heartbeat. So for example, if you were to locate your pulse, and if you were to synchronize your breathing to the speed of your pulse, as you breathe in, pay attention to the speed of your heart rate. And as you breathe out, pay attention to the speed of the heart rate. Typically, as you breathe in, your heart rate should be getting faster. And as you breathe out, your heart rate should be getting slower. And that would be optimal because you see that there's a timing between beat is different on the breath in versus the breath out. Because on the breath in during rest, the vagus nerve, it steps back a little bit. So it's more sympathetically driven. It's more driven by, in terms of the autonomic nervous system, the stress response. And on the breath out itself, that's primarily under the control of the vagus nerve. And by slowing down the breath out, the exhalation, you bring the body into relaxation. It's the exhalation which is the key in terms of helping to bring the body into relaxation. And it's probably because throughout our evolution, whenever we were stressed, we never would have slow breathing. Whenever we were stressed, we always had fast breathing. So the brain has identified stress with fast breathing and fast breathing with stress. Stress speeds up your breathing, but if you intentionally speed up your breathing, you will bring the body into stress. And relaxation slows down the breath. But if you slow down your breathing, you will also bring the body into relaxation. Now, if we look at this with mouth breathing, With mouth breathing during wakefulness, the air that's coming into the body has very little resistance because it's your nose that imposes a resistance to your breathing during the day that's 2 to 3 times that of the mouth. So nasal breathing slows down the air as it comes into the body. When you breathe through your nose, you are typically breathing slower. When you breathe through the nose, you typically breathe deeper. And when you breathe through the nose, you typically breathe lighter. So light, slow, deep breathing are really what we want to get to. And the best way to remember that would be LSD. Light breathing is focused on the biochemistry. Slow breathing is focused on the coherent of breathing. And deep breathing is focused on lateral expansion and contraction of the lower ribs. But they are all interconnected. When you breathe through the nose, you're more likely to breathe light, you're more likely to breathe slow, and you're more likely to breathe deep. When you breathe deep, using the diaphragm, a greater amplitude of the diaphragm, you are also more likely to breathe through the nose, and you are also more likely to breathe slow. So, the 25 to 50% of studied children who persistently mouth breathe, what can we say in terms of the impact that that's having on the autonomic nervous system? I was that child. I was that teenager into my early 20s. I was constantly highly strung. How can you be in a calm state of mind unless breathing is addressed? And for the adult who is persistently mouth breathing, or for the adult who is spending maybe 6 or 8 hours every night with their mouth open, unrefreshed sleep, waking up tired in the morning, walking to their car with their mouth open, periodically breathing through the mouth, periodically breathing through the nose, not really having a whole lot of attention on their breathing, typically breathing fast in upper chest. What impact is that having on the mind? It's also going to put them into a stress state. It was only in March of 2017 that Stanford Medical School, they identified a new structure in the brain, and they reported that this structure in the brain was spying on your breathing. And when you breathe fast, this structure in the brain is reporting its findings or relaying messages to the rest of the brain, sending signals of agitation. So fast breathing typically will agitate the brain. Now, fast breathing is also more likely to wake you from sleep. Now, if we think of people with sleep problems, and that's going to include snoring, that will include obstructive sleep apnea, hypopnea, that will include insomnia. In one paper, 67% of people with obstructive sleep apnea have insomnia. And when obstructive sleep apnea and insomnia go together, those individuals are at a greater risk of depression. Now, there is such a link between the 3 main functions of the human body: breathing, sleep, and mental health. If you are stressed, your breathing is faster. And if you have faster breathing, you are more likely to have agitation of the mind and stress. If you have agitation of the mind, it's going to impact your sleep. Because if you have a lot of thoughts going through your head and different worries and, incessant and repetitive thinking going through the mind, it's very difficult to fall asleep. You're more likely to spend the night twisting and turning. You wake up feeling tired. So agitation of the mind impacts sleep. But if you have poor sleep, that's also going to cause agitation of the mind, because if you don't wake up feeling refreshed, you are not going to be able to concentrate. You are not going to be able to focus. You are not going to be productive. And that in turn increases anxiety. So we have to look at the 3 pillars here. Sleep is impacting breathing. Breathing is impacting sleep. Breathing is impacting anxiety. Anxiety is impacting breathing. Anxiety is impacting sleep, and sleep is impacting anxiety. It's all interlinked. So the person who comes into me with depression, and I say to them, how do you feel when you wake up in the morning? And they tell me they wake up and they are feeling absolutely exhausted. And then I ask, has anybody ever referred you to a sleep study? Has anybody investigated your sleep quality? And they say no. And that's typically the answer. Because the healthcare professional is assuming that the person with depression is the depression which is causing their exhaustion. But maybe we have to ask the question, could it be the exhaustion which is causing their depression? Could it be the sleep apnea, which is causing their depression? And therefore, if we just address that individual's mental health using cognitive behavioral therapy or medication, for example, it is not going to address the real issue. We also have to address respiratory physiology. So I want to go through the interlink with that, and we'll give you some practical exercises, starting off very, very easy. I also want to go through the efficiency of breathing. Every breath that you take, not all of that air that you take into your nose or mouth arrives in the small air sacs in the lungs. And we have to consider that in the human lungs, in the adult human lungs, there are about 5 million small air sacs, alveoli. And each small air sac is surrounded by a blood vessel, by a capillary. And if we were to open up the area of contact between the alveoli, where air is passing into, and the capillaries, where oxygen is passing into the blood, if we were to open up that area of contact, it is between 50 and 100 square meters. So every breath that you take, you're taking that from the atmosphere into your lungs. And the exposure of the atmospheric air to the body in terms of coming into the lungs is 50 to 100 square meters. Now you compare that to the exposure of the skin to the atmosphere. If you were totally naked on a hot day, the area of exposure of your skin to the atmosphere is 2 meters squared. Your lungs are up to 50 times more exposed to the atmosphere than your skin. We protect the skin, but we don't protect the lungs. And the reason I talk about this is I've been on this journey for 20 years. And I remember meeting with various healthcare professionals, and this is not a criticism. This is just a reality. This is just an experience. And I meet with the Asthma Society of Ireland, and I speak to them. You have many members with asthma, 500,000 people with asthma in this country. And in terms of that, I would ask, I think breathing through the nose, it makes a lot of sense in terms of helping asthma. Asthma is an airways condition which is affected by cold, dry air. If you go for a run, especially if you're prone to asthma, and if you breathe hard and fast and you take that cold, dry air into your lungs, the airways can constrict. And it is well known that breathing cold, dry air into your lungs causes moisture to be sucked out of the airway of the lungs, and this in turn is causing constriction and causing inflammation. And inflammation is one of the components regarded in asthma. So when I meet with the Asthma Society of Ireland, we speak about nose breathing, and to this day, I'm not aware of any asthma society in any country in the world which tells their members to breathe through their nose. I still haven't fully got the answer on that one. I really don't know what's going on, but it just doesn't make sense. If you were somebody with asthma, absolutely learn to breathe through your nose. I switched to nasal breathing in 1998. I practiced an exercise to decongest my nose, and then that night I wore breathe right strips across my nose to help keep my nose open, because remember, when we have asthma, we don't just have asthma, our nose is typically stuffed up. And when we have a stuffy nose, we don't just have a stuffy nose, our sleep is likely to be impacted. So if anybody comes into me with hay fever, or if they come into me with a breathing pattern disorder, or if they come into me with fast breathing or upper chest breathing or anxiety, I know it's not just related. It's not just a breathing pattern problem they have. They are also likely to be more breathless during physical exercise. They're more likely to be stressed, and their sleep is impacted. And this is the link that breathing has. It's breathing. We cannot just see the human body as unique parts. It is a whole, and every part of the human body is interconnected. There's a bidirectional feedback there. We know that, and we should be taking that into consideration. So, one more aspect in terms of the theory, and I will go through sleep apnea, obstructive sleep apnea. I will go through snoring. I also want to touch on COVID a little bit, and I also want to touch on women's breathing. I, as a man, have completely ignored this up until about 3 months ago. I had read about it here and there, a little bit here, a little bit there, and maybe because of my Catholic background, I was afraid to open my mouth. Shyness would come out. But women's breathing is very much different to men's breathing. And this has been known about since 1905. And despite this, and despite the research, but most of the research, unfortunately, is performed by men. Women, especially the younger women, when they're going through the monthly cycle, days 10 to days 22. So we're talking about post-ovulation during the luteal phase. There is an increase of a hormone called progesterone. And progesterone is a respiratory stimulant. And it can stimulate breathing so much that carbon dioxide levels in the blood can drop by 25%. Now, what this means is that if you have a female with already poor breathing patterns, and she is going into days 10 to 22, and there is an increase of progesterone, she will have an amplification of her symptoms during that time because of the change to her breathing patterns. For example, when you hyperventilate, you have increased pain. That has been written about for decades. Pain thresholds lower, pain perception increase. So individual females that have pain will typically experience more pain days 10 to days 22. There are studies showing that females who go in for a test of fibromyalgia, and many of the diagnosis of fibromyalgia is done on pain, that females that go in to do the test between days 10 and 22 can have a positive diagnosis of fibromyalgia. But if they go in and they do the test at other times of the monthly cycle, they don't have a positive diagnosis of fibromyalgia. What other way would it affect the female? Fatigue is going to be more likely days 10 to days 22. Temporomandibular joint pain, muscle pain, rheumatoid arthritis, epilepsy, panic disorder, and anxiety. All of those conditions, which are relatively common, are impacted by in the monthly cycle during days 10 to days 22. And the research is there if we do a little bit of digging. So I've just completed writing a new book. I submitted it to my book agent on Monday, and I included a chapter on female breathing. Because unfortunately, breathing pattern disorders affect more women than men. And in some papers, it shows that breathing pattern disorders affect from 2 to 7 times more females than men. But this is being overlooked. Nobody has really put out a breathing technique for females. So for younger females, it's very important that we improve their functional breathing patterns. Because if they have good breathing going into days 10 and 22, they will be able to negate some of the symptoms that are caused by the hyperventilation during this time as a result of the change of hormones. The other aspect in terms of female is that women who go into going through menopause, for example, postmenopausal women, age say between 47 and 54 years of age, obstructive sleep apnea increases 300% of an increase. Now that's huge. We have to recognize that it's possible that progesterone is a protective element or a protective hormone against sleep apnea in younger years. And of course, as hormones, are changing, and the women going through menopause or postmenopause aren't getting that spike of progesterone. It's not serving to protect, and there's an increased risk of obstructive sleep apnea. And of course, with that, as we get older and as the female gets older, there is a greater maybe tendency to put on some weight, and especially weight in the upper part of the body, in the throat and the belly. And this in turn is going to feed into sleep disorder breathing. So that's one aspect of it. When we are working with people with anxiety and depression and panic disorder, we have to be very careful, because with some groups with panic disorder, they can have a heightened sensitivity to air hunger. So for example, and I've made lots of mistakes with this one. In 2010 to 2013, I gave out courses on mindfulness and functional breathing in Ireland. And during that time, because it was as a result of the economic crash, there was a lot of anxiety. I had about 3,000 females attend these courses in the course between 2010 and 2013. Well, I put them out there, and it wasn't by chance that 3,000 females attended, but 3,000 people attended, but 95% of them were females. Obviously, men thought that they were fine, that they didn't need to do breathing exercises, but at least the women were happy to come in and do breathing exercises. With many of the females who had a tendency towards panic disorder, when I had them slow down their breathing in order to help normalize their blood biochemistry, they would feel air hunger. And instead of the air hunger making them feel relaxed, the air hunger actually put them into a fight or flight response. And myself, in my wisdom at the time, I told them to keep going, keep doing it. And of course, it was entirely the wrong thing to do. So I will talk about that because the air hunger that we experience is basically signifying that carbon dioxide is increased in the blood. And we want to intentionally increase carbon dioxide pressure in the blood. But at the same time, we want to keep the body in relaxation. We don't want to be activating that fight or flight response. For people prone to panic disorder, it's very important that we do have them experience air hunger. Because if I can give them a teaspoon of air hunger over a period of time, I will be able to desensitize their bodily reaction towards that feeling of suffocation. Now, you will probably be aware that people who are having a panic attack, when they were in the throes of symptoms, they were often told to breathe in and out of a paper bag or a bag. The purpose of the bag was to trap carbon dioxide, to pull carbon dioxide from the exhale breath into the bag and to rebreathe that carbon dioxide back into the lungs. With higher CO2 in the lungs, it increases CO2 in the blood, and with higher CO2 in the blood, it increases blood flow to the brain. Carbon dioxide is not just that waste gas. If we think about atmospheric concentrations of carbon dioxide, it's 0.04% of the atmosphere. Atmospheric pressure at sea level is 760 millimeters of mercury. The carbon dioxide pressure in the lungs is 5%. So 5% of the atmosphere of carbon dioxide should be inside in the human body. We need a carbon dioxide pressure that's much more than that in the atmosphere. And it's the volume of air that we breathe per minute which solely determines the carbon dioxide in the lungs. And it's the carbon dioxide in the lungs that determines the carbon dioxide in the blood. If, for example, we breathe hard and fast, we remove too much carbon dioxide from the blood through the lungs, and the loss of carbon dioxide causes blood vessels to constrict. 70,000 miles of blood vessels throughout the human body constrict as a result of breathing too hard. But not only that, discovered back in 1904, called the Bohr Effect, and the Bohr Effect states the role of the carbon dioxide in the blood as a catalyst of the release of oxygen from the red blood cells. So you can imagine, you take air into your lungs, oxygen passes from the lungs into the blood. Oxygen in the blood is mainly carried by hemoglobin molecules. Hemoglobin is a protein within the red blood cell. 98% of your oxygen is carried by hemoglobin. But what is the catalyst that causes hemoglobin to release oxygen to the tissues and organs? That catalyst, one of the catalysts, is carbon dioxide. And if we are breathing too much air, we lose too much carbon dioxide, and this in turn is causing an increase to blood pH. And what happens then is that hemoglobin holds onto oxygen more readily. So the ironic thing about breathing, the harder and faster we breathe, the less oxygen that gets delivered throughout the body. Now, despite that, how many times have you went to a breathing class that you've been told to take full breaths, big breaths, that you hear everybody in the class breathing? You should never hear breathing during any breathing class. You should never hear people breathing during rest. If you went out into nature, you would never see any animal in the corner of the field with a group of other animals all breathing harder because they have this belief that it's good to big breathe. Have you ever seen your dog intentionally breathe harder because the dog has a belief that it's good to big breathe? But yet human beings, we seem to have this belief that it's good to big breathe. Okay. So my point here is, by changing biochemistry, you can influence your blood circulation and oxygen delivery. Okay. How would you know where your breathing is at? And one very simple test to screen of how well you breathe is called the control pause from the Buteyko method, or the Bolt score from the oxygen advantage. They both mean the same thing. You're sitting down for about 5 minutes. You allow your breathing to rest, to recover. And you get a timer. Maybe you have a phone or you have something on your computer. And what I would like you to do is, whenever you're ready, you take a normal breath in through your nose and a normal breath out through your nose. And you pinch your nose with your fingers. Or if you just want to hold your breath. And you are timing it in seconds until you feel the first definite desire to breathe, or the first stress of the body to take a breath. The control pause it's not a measurement of the maximum length of your breath hold time. It's a measurement of how long you can hold your breath for after a normal exhalation until the brain reacts. How long does it take for the brain to react to the fact that you've stopped breathing? When the brain reacts, it reacts by sending a stress to breathe, or a desire to breathe, or you experience involuntary contractions of the diaphragm. But as I said at the start, your diaphragm breathing muscle is not just isolated, that there is a connection between the diaphragm breathing muscle and the upper airway dilator muscles, or the muscles in the throat. Typically, as you feel an involuntary contraction of the diaphragm, you might also feel a contraction in the throat. And at the end, your breath should be fairly normal. So what are we looking for? Well, in a paper by Kiesel, and this was published back in 2018, and he looked at 51 individuals, 51 subjects, and he tested their breathing from a biochemical point of view, from a biomechanical point of view, and also from a psychophysiological point of view. His conclusion was that breath hold time, and it was exactly what we did, how we described it. If it was above 25 seconds, there is an 89% chance that dysfunctional breathing is not present. Or if you have a breath hold time above 25 seconds, there is 11% chance that dysfunctional breathing is present. Or you could say, well, if your Bolt score or control pause is less than 25 seconds, there is a very high chance that you have dysfunctional breathing. If you have a Bolt score of 10 seconds, I'm going to predict this. Walk and you are breathing harder. You will have effortless breathing. You have disproportionate breathlessness for the degree of physical exercise. You have exercise intolerance. Number 2, you may notice that your breathing is relatively fast during rest. A little bit upper, well, of course, it's going to be upper chest, but you may feel that, you can't take a satisfying breath, that you feel air hunger during rest. Number 3, breath hold time provides you good feedback if you have sleep disorder breathing. There is one phenotype in sleep apnea, in obstructive sleep apnea, called loop gain. And loop gain can be measured using breath hold time. If you have a low breath hold time, it means that you have harder and faster breathing. And what this means is that if you stop breathing during sleep, if you have an apnea, that if you have a low breath hold time, when you resume breathing with exaggerated ventilation. And that hard breathing, that fast breathing, those large breaths that you take after the breath hold will cause too much carbon dioxide to be lost from the blood through the lungs. And as a result, the brain doesn't send a signal to breathe. So this contributes to a central apnea, but also when the brain doesn't send a signal to breathe, the output from the brain to the upper airway dilator muscles is also reduced, and this feeds into an obstructive sleep apnea. So your breath hold time will provide you a good feedback of, your exercise tolerance, your functional breathing patterns. If you have asthma, for example, you will continue to have chest tightness, coughing, wheezing, breathlessness until your breath hold time is about 25 seconds. Now, granted, you are likely to be on medication for asthma, and as a result of the medication, you're not going to have your symptoms because the medication is stopping your symptoms. But if you weren't on the medication, your breath hold time would be quite low and your symptoms would be evident. So we need to improve breath hold time. And as breath hold time improves, you are more likely to breathe using the diaphragm. You are more likely to breathe with greater amplitude of the diaphragm. As your breath hold time improves and increases, you are more likely to have slow breathing. As your breath hold time increases, you are more likely to have regular breathing. Conversely, if you have a low breath hold time, you are more likely to breathe upper chest, you are more likely to have faster breathing, you are more likely to have irregular breathing, and you are less likely to have a natural pause following exhalation. The first exercise I'm going to start you off with is many small breath holds, because it's an easy exercise to do, and pretty much everybody can do it. From that then, I will go into breathe light from a biochemical point of view. We will do a few sessions of that. After that, we will look at breathe light from a biomechanical point of view. Then we will look at coherent breathing and heart rate variability. And from that then, we will look at functional breathing during physical exercise. And with that then, we will talk about breathing during sleep. So the first exercise that I would like you to start off with is many small breath holds. So whenever you're ready, take a normal breath in and out through your nose and either pinch your nose or hold your breath. 5, 4, 3, 2, 1. Let go, but breathe in through your nose and breathe normal for 10 seconds. And again, take a normal breath in and out, pinch your nose and hold. 5, 4, 3, 2, 1. Let go, breathe in and breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in, breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in, breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in, breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in, breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in and breathe normal for 10 seconds. And again, take a normal breath in and out and hold. 5, 4, 3, 2, 1. Let go, breathe in and breathe normal for 10 seconds. Okay, I think you will have the hang of that exercise by now. You hold your breath for between 3 and 5 seconds and you breathe normally for 10 seconds. The rule of thumb is, if your control pause or both score is low, for example, if you're in high stress, chronic fatigue, if you have asthma symptoms, if you have panic symptoms or hyperventilation, never hold your breath for more than your control pause or your both score at that time. So that last exercise is an emergency exercise. If you have labored breathing, when you have labored breathing and your breathing is feeling effortful, your breathing is harder and faster, it's very difficult to slow it down because the drive to breathe is too strong. Also, if you're stressed, the last thing you want to do is slow down your breathing. If somebody has a lot of anxiety or panic, the last thing they want to do is slow down their breathing. So for breathing recovery, that last exercise is best. If you're having symptoms whereby your breathing is labored, it's much easier to get your breathing under control by holding your breath. So for people coming in with COPD, for people with chest infections that they can't shift, for people who are recovering post-COVID that have respiratory distress, they have great difficulty in doing breathing exercises. I have them do that last exercise and that's it. And I ask them to do it for 10 minutes every hour. If they have a lot of symptoms, I prescribe 10 minutes every hour and nasal breathing in between. And what that helps to do is it helps to calm down their breathing. It helps to open up the airways. When breathing calms down and breathing feels a little bit easier, the control pause or both scores increasing, and then it's easier to do the other exercises. The next exercise that we are going to do is, I'll actually do the exercise to decongest the nose. However, don't do this exercise if you're pregnant, or if you have any serious medical conditions, or if you have any cardiovascular issues. So this exercise involves holding of the breath. Now, generally, it's very safe. It would be very similar to if you went for a swim, and if you went underwater for a little period of time and you come back up. So it's a very natural thing for human beings to do. It's known since 1923 that when you hold your breath, you help open up the nose. And I first came across this exercise back in 1998. And I always had a stuffy nose. I'd always chronic nasal obstruction. And as a result, it's inevitable that you mouth breathe. No child or adult is going to breathe through the nose if they experience air hunger breathing through the nose. It's not the degree of nasal obstruction that's the issue. It's the feeling of air hunger that's the issue. And you may have some children and adults with no nasal obstruction, but with a small nasal airway and a poor breathing pattern. That too will fuel a feeling of air hunger, and as a result, they continue breathing through the mouth. So we know that 12% of the population with adequate nasal airways typically mouth breathe. But with those with a smaller nose, it increases quite significantly to 90%. So if the nasal anatomy is reduced to the point that you feel air hunger breathing through the nose, you typically don't breathe through your nose, and that was me. So when I started doing this exercise, I was able to decongest my nose temporarily. It's only when you get your control pause to about 20 or 25 seconds that your nose will be more permanently free. But at the same time, the fact that I was able to decongest my nose temporarily, I knew there was something in the breathing exercises. Another aspect about this is, the more you breathe through your nose, the better your nose works. So even if you do have some slight air hunger, even if you do feel a little bit uncomfortable breathing through the nose, continue breathing through the nose. But try not to be forcing the air in and out. Gently slow down your breathing. And in a little while, I will give you an exercise to improve your breathing efficiency, that breath by breath, that you can enhance the amount of air that's reaching the smaller air sacs in the lungs. So in order for you to have adequate oxygen, you don't need to breathe so hard. And we will go through that. To decongest your nose, perform the following. Take a normal breath in through your nose and normal breath out. Either hold your breath or pinch your nose. And as you hold your breath, gently nod your head up and down or move your body side to side. The whole point is hold your breath during movement. And you could start off, take a normal breath in and out, hold your breath and move your body side to side as you hold your breath. And continue holding your breath until you feel a relatively strong air hunger. And then let go, but breathe in through your nose. So the first couple you could do relatively easy. So you give yourself a warm up. And then you're breathing in and out through your nose. So we wait about 30 seconds to a minute, and then we do it again. To open up your nose, you typically need to hold your breath for at least 30 seconds. It's not known how this opens up your nose. It may be that holding the breath will increase carbon dioxide in the blood. And as carbon dioxide increases in the blood vessels in the nose, which are swollen, which are expanded, which are inflamed, shrink. It may be that as you hold your breath, nitric oxide is pooling in the nose. It may be as you hold your breath, you activate the body's sympathetic response, and this helps to decongest the nose. and again. Take a normal breath in and out and hold and sway. Sway holding the breath. And I would like you to hold your breath for absolutely as long as you can, but without being stressed. At the end, make sure you let go, you breathe in through your nose and get your breathing under control. Even if you have a head cold, you will be able to open up your nose. Granted, when you have a head cold and you do this exercise, it will temporarily free your nose, and after a few minutes your nose gets stuffy again, but you do it again. It's our own experience over the years, and I've worked with about 8,000 people, probably minimum. I haven't been able to keep track with it. With doing this exercise and other exercises, only 15 people we weren't able to get breathing through their nose. 15 people with really severely deviated septum or with nasal polyps that we could not get them to breathe through the nose. And the wonderful thing about the nose is you don't need to have a perfect nose to breathe through it. 60% of the Western population have a deviated septum. This is when the cartilage and the bone in the nose dividing the left side of the nose to the right is crooked. You see my nose, it's by no means perfect. In actual fact, I see Alicia Pasca and she will see my nose from a mile off. She will say that his right nostril is tiny, his left nostril is a bit bigger, his nose is shaped like an S, and yet I can still breathe through my nose. So you don't need a perfect nose to breathe through it. The key is, can you breathe comfortably through what you have? So again, take a normal breath in and out through your nose, hold your breath, and sway holding your breath for as long as you can. And as you hold your breath, relax into the body. Keep relaxing, keep pushing, keep going, keep holding, keep going. You will feel involuntary contractions of your breathing muscles. When you let go, but get your breathing under control. And typically we do this about 6 times. We use the same exercise for children, for teenagers, for adults. If a child has pulmonary hypertension or epilepsy or serious medical conditions, we don't do the strong breath hold. Instead, we do the easier breath holds. But children love to hold their breath. How many times have you went to a swimming pool? You see younger kids, they throw a diving stick into the water and in they go after the diving stick. And I'm sure your kids have done that. It's very normal for the human being to hold the breath. And again, take a normal breath in and out through your nose, hold your nose and sway, holding your breath. And hold your breath and keep relaxing into the body and hold your breath until you feel a relatively strong air hunger. And then to let go, but to breathe in through your nose and continue breathing in through your nose. So we will do that exercise about 2 more times, and then we will move on to the next exercise. So the key with nasal breathing is nasal breathing during rest, nasal breathing during physical exercise, and nasal breathing during sleep. The benefits of nasal breathing in comparison to mouth breathing, there's no comparison. Just to give you a snapshot, if you breathe through your nose during physical exercise, you increase oxygen uptake in the blood. You increase oxygen delivery to the tissues. The fraction of expired oxygen is less. Your body is more economical at utilizing oxygen when you breathe through your nose. When you breathe through your nose during physical exercise over a period of time, adaptations take place in the body that you have a higher tolerance to the gas carbon dioxide. And this translates into reduced breathlessness. So initially, when you switch from mouth to nose breathing during physical exercise, initially it's more difficult because the air hunger is stronger. And the air hunger is stronger because carbon dioxide is not able to leave the body as quickly from the lungs through the nose as it would be through the mouth. However, if you expose your body to that higher air hunger over a period of time with sustained physical exercise, the adaptation that takes place is that your body is able to cope with higher carbon dioxide. As a result, your breathlessness during physical exercise reduces. The amount of air that you need to perform a given intensity and duration of physical exercise is less. Nasal breathing during physical exercise imparts a greater amplitude of the diaphragm, and as we spoke, functional breathing and functional movement go together. If your breathing is functional, your movement is more likely to be functional, and conversely, if your breathing is dysfunctional, your movement is dysfunctional. If you have dysfunctional movement, you are more likely to be at risk of injury. For example, 87.5% of people who pass the functional movement screen, which is a test carried out typically by strength and conditioning coaches and by physical therapists, etc., 87% of people who pass that test are classified as diaphragmatic breathers. Now, how common is it for the normal population to be typically upper chest breathing and breathing that little bit faster? In Kiesel's paper, looking at 51 subjects, only 5 of those people had normal breathing, and 12 of them failed everything. So 20% failed all 3 dimensions of breathing, only 5 passed all 3 dimensions, and then the remainder failed at least 1 or 2 of those, one or two of those dimensions. So dysfunctional breathing is relatively more common than we think. And we know in the anxiety population, it's as high as 80%. So you can imagine all of those individuals with anxiety, with panic disorder, with high stress, they're doing different therapies, they're taking medication, but their respiratory physiology is not correct. And cognitive behavioral therapy does not change respiratory physiology, it does not change it. You can do all of the CBT in the world. It's not going to change your respiratory physiology. And unless the person with anxiety learns to change their respiratory physiology, they will remain stuck in that fight or flight or agitation of the mind, stress state, anxiety. Let's do it again. Take a normal breath in and out through your nose, pinch your nose, hold your breath, and sway holding your breath until you can feel a relatively strong air hunger, and then to let go to breathe in through your nose. But the objective here is to hold your breath for relatively a long time. As you hold your breath, you will feel involuntary contractions of your breathing muscles. You will feel the diaphragm contract. The diaphragm is contracting on the basis of the messages coming from the brain. The brain is noticing that there's an increase of CO2 in the blood, and carbon dioxide is the primary stimulus to breathe. And the brain is sending a message via the phrenic nerve to the diaphragm, and the diaphragm is contracting in an effort that air can be drawn into the body. Next exercise. This one here, you can pay attention to your body. If you have panic disorder, only do this next exercise for 30 seconds and then take a rest for 1 minute. But if you don't have panic disorder and if you feel comfortable doing this exercise, do it for the full 4 minutes. I would like you to put one hand on your chest and one hand just above your navel. So you have one hand on your chest and one hand just above your navel. I would like you to tune into your breathing patterns. I would like you to feel the airflow as it comes into your nose and to feel the airflow as it leaves your nose. Feel the slightly colder air coming into your nose and feel the slightly warmer air as it leaves your nose. So work to feel your breathing. Concentrate on your breathing. How long can you concentrate on your breathing for before your mind wanders? And if you find that your mind is wandering a lot, you will get even more out of this exercise by training the brain to concentrate on the breath. Because if your mind is wandering during this exercise, your mind is wandering pretty much most of the time. And a wandering mind, it affects our ability to concentrate. Concentration is our ability to hold our attention on a subject matter for a period of time without distraction. So I would like you to concentrate. I would like you to focus. I would like you to feel the slightly colder air coming into your nose and to feel the slightly warmer air as it leaves your nose. Really concentrate on the speed of the breath coming into your nose and really concentrate on the speed of the breath as it leaves your nose. And as you feel your breathing, gently slow down the speed of the air coming into your nose. And at the top of the breath, bring a total feeling of relaxation to the body and allow a relaxed and a gentle breath out. After you breathe out, wait until you feel the need to breathe in again, and then take a very soft and gentle breath in. Take a very soft and slow, gentle breath in, and at the top of the breath, bring a total feeling of relaxation to the body and allow a relaxed and a gentle breath out. The length of the breath out should be at least 1.5 times the length of the breath in. So on the in breath, you are really slowing down the speed of the air coming into your nose. And on the out breath, you are bringing a total feeling of relaxation to the body and allowing a relaxed and a gentle breath out. Allow the air to leave the body effortlessly and have a normal and complete exhalation, allowing the diaphragm to move back up to its resting position. And then when you need to take a breath in again, really slow down the speed of the breath in, almost that you're hardly breathing in any air at all. Can you imagine breathing in so smooth, so soft, so calm, that the fine hairs within the nostrils do not move? You are really slowing down the speed of the breath in, and at the top of the breath, a total feeling of relaxation to the body and a relaxed and gentle breath out. The objective is that as you slow down the speed of the air that you breathe, that you take less air into your body. And as you take less air into your body, carbon dioxide will increase slightly in the blood. Carbon dioxide is the primary stimulus to breathe. So as you breathe less air, carbon dioxide increases and you feel air hunger. You are doing it correctly when you feel air hunger, when you feel that you would like to take in more air, when you feel that you are not getting enough air, when you feel that you are slightly breathless. So again, how do you create air hunger? Gently slow down the speed of the air coming into the nose. At the top of the breath, bring a total feeling of relaxation to the body and allow a relaxed and a gentle breath out. After you breathe out, wait until you feel the need to breathe in, and when you feel the need to breathe in, take a very soft and slow, gentle breath in. Concentrate on the airflow coming in and out of your nose. Bring your attention out of the mind on the inside of the nostrils. The inside of the nose is very sensitive to airflow. So as you feel the inside of your nose, gently slow down your breathing so that you feel less turbulence in the nose. You are doing it correctly if you feel air hunger. As you do it, pay attention to the saliva in your mouth. Is it less? Is it more? Is it the same? As you do it, pay attention to the temperature of your hands internally, not just because you have your hands against your body, but the internal temperature. As you do it, pay attention to whether you feel more drowsy or whether you feel more alert. As you slow down your breathing and you're changing the biochemistry in terms of carbon dioxide increasing in the blood, the mind is more anchored to the breath. You are slowing down the breath, you're slowing down the inhalation, and on the exhalation, you're having a complete and relaxed and slow and prolonged exhalation. So not only are you helping to normalize your respiratory volume or the amount of air that you breathe, but you are also helping to activate the body's relaxation response. This is a great exercise to do for about 15 minutes before you go to sleep. Many people are not able to switch off. Many people are constantly switched on. In order to have a good night's sleep, you have to be able to switch off. You can switch off, you can down-regulate, you can activate the body's relaxation response by gently slowing down your breathing. As you do that exercise, if you had air hunger and provided that you don't feel stressed, you should notice that you had increased watery saliva in the mouth. You may also know that you feel drowsy. You may also notice that you've got increased body temperature, or at least increased temperature of your fingers. So the objective with that exercise is you are doing it correctly if you feel slightly suffocated, but you don't want to feel stressed. If the air hunger is too much, that you feel stressed, you take a rest. If the air hunger is too much, that you have involuntary contractions of your breathing muscles, you take a rest. It's almost that you want to gently slow down your breathing, not by holding your breath, not by tensing your breathing muscles, not by freezing your breathing, but just by focusing on the airflow coming in and out of your nose. You slow down the speed of the air coming into the body, and as you do that, carbon dioxide increases in the blood because you breathe less air. Exposing your body to higher carbon dioxide, the theory is that as you're exposing the body to higher CO2, you are helping to improve the tolerance to the gas carbon dioxide. Or you could look at it another way. You are practicing slow breathing, and this in turn is changing the brain. That's new neural pathways, that the brain, the behavior of breathing is changing due to the practice of the slow breathing. So even after you go back to normal breathing, you will still, with continued and sustained practice of slow breathing over a period of time, this becomes your normal way to breathe. In terms of sleep, I would like you to make the sound of a snore. I'm sure some of you are going to be pretty good at it. So to make the sound of a snore, if you do it through your mouth, you may do it like this. And if you do it through your nose, you may do it like this. So I would like you to make the sound of a snore. Now what I would like you to do is to slow down your breathing. I would like you to really slow down the speed of the air coming into your nose. And I would like you to have a very relaxed and slow breath out. And then slow down the speed of air coming into your nose. And have a very relaxed and slow breath out. And as you slow down your breathing, I would like you to snore. Snore while you breathe slowly. Can you snore so easily when you breathe really slow? As you slow breathe in through your nose, can you snore? So snoring is not just because of the airway being smaller. Snoring is also due to flow. So we need to look at the airway as a pipe. Any engineer who would look at a pipe doesn't just look at the diameter of the pipe. The engineer will also look at flow. Can you imagine a plumber putting piping in your house without considering the amount of water that was supposed to go through it? That's what happens in sleep, because most people are looking at the airway and very few people are looking at flow. And the realization here is that the air that you breathe during the day is determining the air that you breathe during physical exercise and is determining your breathing pattern during sleep. If you're breathing hard and fast during the day, you typically breathe hard and fast during physical exercise, and you also breathe hard and fast during sleep. And snoring is turbulence in the upper airway. Turbulence may be in the nasal pharynx, turbulence if the air is taken in through the mouth. And by the way, mouth snoring stops when you close your mouth. So for example, if you use tape. So if you have tape on your mouth during sleep, your mouth snoring stops. Nose snoring, we may not stop nose snoring, but we can significantly reduce it. We help to get the nose working better. As the nose works better with less congestion of the nose, there's less resistance to cause snoring. But also, we help to normalize breathing volume. And as you breathe slower and as you breathe lighter, there's less turbulence in the upper airway. You know that you are making progress if your control pause or if your Bolt score is increasing. If you snore and if you have a Bolt score of 10 seconds, your snoring will be significantly reduced when your Bolt score or control pause is 15 seconds, or 20 seconds, or 25 seconds. So every 5-second improvement in your Bolt score will help to show, or at least an indicator, that your breathing is becoming lighter. So how do you make lighter breathing? It's that last exercise. You are gently slowing down the speed of the air entering and leaving the nostrils, but by slowing down the breathing sufficiently that you breathe less air. And the objective is that you breathe about 30% less air. Now, if you're feeling drowsy now, or if you're yawning or feeling a little bit sleepy, it's actually a good sign, because you've activated the body's parasympathetic response. And as Dr. Herbert Benson wrote when he published that book back in 1975 called The Relaxation Response, he said stress makes people sick. And on the basis that stress makes people sick, relaxation helps to make them better. Now, that last exercise that you did is addressing the biochemistry of breathing. However, if you were to monitor your heart rate variability during the exercise, you will see that your HRV will drop during the exercise. However, after the exercise, your heart rate variability will increase. So that last exercise, which is inducing a slightly elevated carbon dioxide in the blood, will improve HRV. Okay, next exercise. I'm going to have you place your finger. I'm not sure how comfortable you are with your finger underneath your nose, given now that everybody is, you can maybe wash your hands or whatever. You have your finger underneath your nose. And I want you to take a very soft breath in through your nose. And as you breathe out, I want you to pretend that your finger is a feather. And I want you to breathe so lightly that the feather doesn't move. So this is a very traditional Buteyko exercise. And then as you breathe in, breathe very, very lightly, almost that you are hardly breathing at all. And at the top of the breath, bring a total feeling of relaxation to the body, and breathe out so slowly, almost that you feel hardly any air on your finger. So you're taking a very soft, gentle breath in, and you have a really slow and relaxed breath out, and the objective is that you feel less air on the finger. I would like you to continue that for the next 2 to 3 minutes. You've heard of opera singers that they were trained to sing in front of a candle, and the whole objective was to have conservation of their breath, that they would sing and not blow out the flame. So with this, I want you to imagine that your breathing is so light that you are not blowing out the flame. How efficient are you with your breathing? Now, the ironic thing here is that as you slow down your breathing and breathe less air, your blood vessels will open up, your blood vessels will dilate. But also as you slow down your breathing, the nitric oxide that's coming from the nasal cavity into your lungs will increase. Slow breathing and breath holding increase the concentrations of nitric oxide in the nasal cavity, and nitric oxide plays a role in the sterilization of incoming air as a bronchodilator. It's antiviral, it's antibacterial, but it also helps to redistribute the blood throughout the lungs. So gently slow down your breathing, and as you feel the air hunger, imagine that your blood vessels are opening up and that there's increased oxygen delivery throughout the body. And that slow and gentle and relaxed exhalation is helping to activate the body's relaxation response. It's the exhalation that's under the control of the parasympathetic nervous system, but it's also the exhalation which is influencing the parasympathetic nervous system. And it's a slow and relaxed exhalation that brings the body into a better balance in terms of activating the relaxation response. So again, you're feeling the airflow coming into your nose, and at the top of the breath, bring a total feeling of relaxation to the body, and you're having a really slow and relaxed exhalation. Can you breathe so slowly that the feather on the finger doesn't move? Can you breathe so slowly, just like the opera singer? Your breathing is so light that you don't blow out the candle flame. This soft and gentle and relaxed breathing, and by doing this, then you're helping to change breathing patterns and take a rest. So now what I would like you to do is to go on to the biomechanics of breathing. And we spoke of the diaphragm breathing muscle as being the main muscle in respiration. And the diaphragm breathing muscle is not just for respiration, but it also provides stabilization of the spine. So you can imagine somebody lifting a weight. As they breathe in, as they lift the weight, they typically breathe in and hold their breath. And as they breathe in, their diaphragm is moving downwards and they hold their breath. And what happens then is their diaphragm is moving down, and their abdomen, they brace the abdomen, almost like the abdomen is like a pneumatic balloon. And this is providing stabilization for the spine so that the spine doesn't buckle. So with this, I would like you to have your hands on either side of your lower ribs. So the lower two ribs is to place your hands either side. And as you breathe in, you should feel that your lower ribs are moving outwards. So when I'm talking about the lower ribs, I'm talking just at the base of the lungs on your sides, that you have your hands on the lower two ribs. And the reason that I'm having your hands on your sides is because it's the lateral expansion and contraction of the lower ribs that give a gauge of the generation of what's called intra-abdominal pressure. And intra-abdominal pressure is important for the role of the diaphragm in terms of functional breathing and functional movement. So as you breathe in, your ribs should gently move out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving out. And you shouldn't hear your breathing. It should be so light. And as you breathe out, your ribs are gently moving in. This is deep breathing in the true sense of the word. As you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And its deep breathing is evident by lateral expansion and contraction of the lower ribs, because it takes intra-abdominal pressure to push the ribs outwards. As you breathe in, your ribs are gently moving out. And as you breathe out, your ribs are gently moving in. And as you breathe in, your ribs are gently moving outwards. And as you breathe out, your ribs are gently moving in. And continue with that. Now what I'm going to do is I'm going to time your breathing. And I'm going to time your breathing to 5 seconds in and 5 seconds out. So that's one breath cycle is 10 seconds. So that's 6 breaths per minute. And this is the optimum breathing rate to stimulate the vagus nerve, but to influence the autonomic functioning of the body, and also to increase the sensitivity of baroreceptors, which are pressure receptors located in the major blood vessels, in the aorta and in the carotid arteries. The pressure receptors are constantly monitoring your blood pressure. When you have an increase of blood pressure, your baroreceptors respond by causing the blood vessels to dilate and your heart rate to come down to reduce. And this helps to normalize your blood pressure. And conversely, if your blood pressure drops, the baroreceptors respond by causing the blood vessels to constrict and the heart rate to increase to normalize your blood pressure. It's very important in terms of the sensitivity of the baroreceptors and vagal tone. And heart rate variability is typically regarded as a measure of vagal tone, vagal traffic. And there's also a relationship between increased vagal tone and reduced inflammation. So bodily systems that are disturbed by stress, you can help to influence them with this next exercise. This is where the body of evidence is. There are hundreds of papers on the application of slowing down your breathing to between 4.5 and 6.5 breaths per minute for influencing the autonomic nervous system. For people with PTSD, for people with fibromyalgia, for people with sleep apnea, for people with hypertension, hypotension, irritable bowel syndrome, asthma, COPD, anxiety, many conditions. So I'm not saying that this is a cure-all, but what I would say is do the research. There's a large body of evidence. And an interesting thing about this, when Bernardi, who is an Italian cardiologist, he looked at, there's a prayer that's said in the Catholic religion called the Rosary. That when individuals were reciting the Rosary, but also when individuals were reciting a mantra taken from, I think it was one part of yoga, and I'm sure also many other different religions which use beads and which recite a mantra, that they looked at the cadence of breathing during the reciting of the Rosary or the mantra in yoga, and more than likely other different religions, that it changed the cadence of breathing to 6 breaths per minute. So it may have been fascinating that you have individuals who have been practicing this for centuries, and modern science since the 1990s, with a researcher called Paul Lehrer, Lehrer, has conducted a huge body of research. And then a cardiologist from Italy called Bernardi, working with his patients with chronic heart failure, looking at the application of breathing for 6 breaths per minute. Even with type 1 diabetes, type 2 diabetes, the application of this is immense. So what I would like you to do is to have your hands on either side of your lower ribs, again as before, and to breathe in for 5 seconds and to breathe out for 5 seconds. Now these will be fuller breaths, but the objective here is don't disproportionately breathe, don't overbreathe. So remember, with breathing, it's a balance between the biochemistry, the biomechanics, and the cadence of the breath. So as you breathe in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5. So just continue with that. It's also much more efficient to take slightly fuller breaths but less of them, because breath for breath, more air actually gets down into the small air sacs in the lungs. I remember reading a paper by Bernardi, and he spoke of his patients with chronic heart failure. They had exercise intolerance. And then I had a student who came in with chronic heart failure, and I was having her wear pulse oximetry, which is a little device that measures the fraction of hemoglobin occupied by oxygen. And as she went for a walk in my studio, her blood oxygen saturation dropped down to 92%, and that's not good. So I had her use what we call the Buteyko Belt, but basically it's a belt that I had her put around her midriff, and I had her put her hands there to bring attention to this region. And as she was walking, I had her slow down her breathing to 6 breaths per minute. And as she slowed down her breathing to 6 breaths per minute, her blood oxygen saturation increased to 96%. And that makes a lot of sense, because before that, she was breathing fast and shallow. And if you breathe fast and shallow, it's the most inefficient and uneconomical way to breathe. But the problem is, people who have breathing issues breathe that way. People with asthma, people with symptoms in terms of respiratory, condition, people who are having COVID, for example, So the very time that we need to breathe functionally, we don't, because the suffocation, feeling of suffocation created during these times drives our breathing to faster and upper chest breathing. But faster and upper chest breathing is only going to feed into suffocation. And the reason being is because we are breathing so inefficient. And later on, I'll show you a chart in terms of the maths. But if you were breathing 20 breaths per minute, and if the size of each breath is 300 ml tidal volume, that gives you 6 liters of air per minute, which would be normal. If you're taking 6 liters of air in through your nose or mouth, the question is, how much of that air actually gets down into the small air sacs in the lungs? To find out the amount of air or the volume of air that gets down into the small air sacs, we have to subtract dead space. And dead space is the last part of the breath which remains in the nose and the throat and the trachea and the bronchi and the bronchioles. Dead space is 150 mil. So if you have an individual breathing 20 breaths per minute, and if the size of each breath is 300 mil, that's giving you a minute ventilation of 6 liters. But to find out alveolar ventilation, we subtract dead space. So therefore, we have 20 breaths per minute multiplied by 300 minus 150. And the answer there is 3 liters. If you breathe 20 breaths per minute and you breathe shallow with a tidal volume of 300 mil, 50% of the air that you breathe stays in your nose and your throat and your trachea and your bronchioles. And 50% of that air gets down into the small air sacs. Can you imagine the very time when we need oxygen transfer and gas exchange to happen most, that we end up wasting 50% of the air that we are breathing? That's also happening with COVID. But that's also happening with people going up into altitude. Any time that we need, that gas exchange is impaired, if atmospheric pressure is reduced, etc., we typically breathe harder and faster. Wrong way to breathe. Instead, breathe slow, breathe deep. So if we have that person who is breathing 20 breaths per minute, slow down their breathing to 12 breaths, their alveolar ventilation will automatically increase from 3 liters to 4.2. And that's already a considerable change. But if we have them even slow their breathing even more, down to 6 breaths per minute, just as what we did there, you increase alveolar ventilation, which is the gas that's entering into the small air sacs in the lungs, from 3 liters to 5.1 liters. So there's no comparison about the efficiency of when we breathe slow. So any of your students, or if you were in a habit of breathing faster and harder, it's going to impact the individual in some way. Okay, so now what I would like you to do is to stand up and walk on the spot, because I think there's no point in just teaching you functional breathing during rest. It's also important to talk about how should you breathe when you go for a walk. And with this, I'm going to have you walk on the spot. Now, the first exercise I'm going to do is go through an exercise we typically use for people who are having severe asthma or panic disorder. And this is a calming exercise to some degree. With this first exercise, don't do this if you're pregnant. Don't do it if you've got any severe medical health issues. But the first exercise, take a normal breath in and out through your nose, pinch your nose and hold your breath, and walk on the spot for 10 paces, holding your breath. So hold your breath as you walk for 10 paces. So you're holding your breath as you walk for 10 paces, and then to let go, but to breathe in through the nose. Now, earlier on, I spoke that people with panic disorder, oftentimes the duration of the air hunger is too much for them, but they will cope quite well with this one, because the duration and the dose of air hunger is relatively light. So you're only holding your breath for 10 paces, and then you can take a rest. So we're going to do it this 5 times, and then we're going to do functional breathing during walking. So again, whenever you're ready, take a normal breath in and out through your nose, pinch your nose and hold your breath, and hold your breath for 10 paces. And then to let go, but to breathe in through the nose, and then to calm your breathing. And then we wait for 30 seconds and we do it again. And again, take a normal breath in and out and hold your breath for 10 paces. So you're holding your breath for 10 paces and then to let go, but to breathe in through your nose. And breathe normal then for a minute or so. So you're just breathing normal for about a minute and then we do it again. Take a normal breath in and out and hold your breath for 10 paces. And then to let go, but to breathe through the nose. Okay. Now, for those of you who are relatively healthy, you can hold your breath for longer, and that will help to open up your nose. And that also helps to change breathing patterns. It's very good for people with asthma. So now what I would like you to do is to have your hands either side of your lower ribs and to start walking on the spot. And as you breathe in, that your ribs are gently moving outwards, and as you breathe out, that your ribs are gently moving inwards. At the same time, I would like you to slow down the speed of the air coming in and out of your nose to breathe light. So focus, as you're walking, focus on the airflow that's coming in and out of your nose. The objective is to gently slow down the speed of the air coming into your nose and to have a complete and relaxed exhalation. Allow the air to leave the body effortlessly. And as you breathe in, the objective is gently soften the speed of air coming into your nose, and at the top of the breath, bring a feeling of relaxation to the body. At the same time, as you breathe light, also breathe deep. That as you breathe in, that the lower ribs are moving out, and as you breathe out, that the lower ribs are moving in. You don't have to breathe big to breathe deep. You don't have to take full breaths or hard breaths to activate the lower regions of the lungs. There's a balance between breathing light, breathing slow, and breathing deep. And just as the woman with chronic heart failure who was having blood oxygen desaturation, now I would like you to start breathing to 6 breaths per minute as you walk. So as you breathe in, so you're walking and you're breathing in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5, in, 2, 3, 4, 5, out, 2, 3, 4, 5. So the objective is take fuller breaths, but less of them. Breathing efficiency is much better when the tidal volume is larger. And it's not that you want to be deliberately really forcing the air into the body, but just that you are breathing just that little bit bigger. So a bigger breath and less respiratory rate. Always bear in mind, a fast respiratory rate, fast and shallow breathing is the wrong thing to do, okay? I want to look at sleep, and the next objective is just looking in terms of a little bit of the theory behind it. And we'll come back to the exercise then towards the end. So just bear with me 1 second here. I want to look at the theory of obstructive sleep apnea, and also even with children. In one paper, which was one study conducted back in 2010, and it was published in the American Journal of Respiratory and Critical Care Medicine. And I think it's very important that we look at this study because, so with this, and this is very interesting because when I first read this, I was a little bit surprised by it, to say the least. The overall efficacy of adenoid tonsillectomy in the treatment of obstructive sleep apnea syndrome in children is unknown. Now, this was written in 2010. So the efficacy of tonsillectomy adenoidectomy wasn't known in 2010, although success rates are likely lower than previously estimated. This paper looked at 578 children, and of that, only 157 kids, 27% of them, had complete resolution of obstructive sleep apnea syndrome. 73% of them continued to have sleep apnea post-tonsillectomy and adenoidectomy. This is pointing that it's not just the size of the tonsils and adenoids which is the problem, but we also have to consider the size and the forward growth of the airway. The individuals who did less well were older children, obese children, and chronic asthma. And chronic asthma is very interesting because we always have known that there's a relationship between asthma and sleep disorder breathing. Sorry there, I'll just put that up so you can get that reference again. I can never pronounce his name, but Bhattacharjee. So some Indian doctor, it would seem.
Bhattacharjee.
Say that again, Samantha.
Bhattacharjee.
Wow, well done. So adenoidectomy, tonsillectomy outcomes in the treatment of obstructive sleep apnea in children, a multi-center retrospective study. So with this, when we see that children and adults with asthma, as asthma severity increases, so does obstructive sleep apnea. We have to consider what's going on. Why could that happen? Well, if you think of your typical person with asthma, a child or an adult, how do we breathe when our lower airways are constricted? We breathe harder, we breathe faster, we breathe up our chest. There's no natural pause between breaths. We are really caught for breathing. And it has to be that the change in the breathing pattern is increasing the risk of sleep apnea. And this would point out that, yes, flow plays a role. Now, we also know that with asthma, breath hold time would reduce. And breath hold time then, as for example, in Messino's paper, as a measurement or an indicator of loop gain in sleep apnea. So a couple of other points that I want to show.
A very quick question.
Yeah.
Someone was wondering if you could show the reference to the 2018 study.
The 2018 study. That was the 2010. That was the one I was talking about, though. We showed the reference to it.
All right.
Did you pick up the reference of it? I think I'll just throw it up again. 1 second. I have a different. So it's a 2010 study. This is the paper in terms of looking at the efficacy of tonsillectomy in children. So there's a couple of other things now that I would like to show. One is the incidence of sleep apnea in the adult population when you breathe through your nose and when you breathe through your mouth. So I'm just waiting for the paper to open up. And this was published just a few months ago in Laryngoscope. So the title of this is The Association Between Breathing Route Oxygen Desaturation and Upper Airway Morphology. And when we scroll down, it's looking at 95 patients with established obstructive sleep apnea. And they were recruited in the study from May 2017 to May 2019. The results were that patients with mouth breathing were associated with increased obstructive sleep apnea severity, worse oximetric variables, and higher body mass index in comparison to those with other breathing routes. The conclusion was that mouth breathing was significantly associated with worse oxygen desaturation and increased degree of upper airway collapse. Therefore, patients with mouth breathing, okay, that doesn't matter. But I'm just going to scroll it down to the numbers involved. With mouth breathing, and I will increase it here 1 second. So with mouth breathing, the AHI, which is the apnea hypopnea index events per hour, is a measurement of severity of sleep apnea. With mouth breathing, it was 52 events per hour, which is severe. With oronasal breathing combined, it was 42 events per hour. And with nasal breathing, it was 27 events per hour. So in the adult population, getting the mouth closed, and by the way, this is just getting the mouth closed. This is not considering improving functional breathing patterns. It's not just enough to close the mouth. We also need to improve the biochemistry of breathing and the biomechanics of breathing. Now, if we scroll down a little bit and we look at the minimal SaO2 blood oxygen saturation, with mouth breathing, it dropped to 64%. And with oronasal breathing, mouth combined, it was 77%. And with nasal breathing, it was 78%. Coming back to 64%, if I had you hold your breath for an absolute maximum, it would be very unlikely that you were able to drop your blood oxygen saturation down that low. The only way you could do it is if you hyperventilated beforehand. If I had you hyperventilate for 10, 15 breaths to get rid of a lot of carbon dioxide from the blood through the lungs, the brain then doesn't send a stimulus to breathe until carbon dioxide climbs back up to that threshold. So as a result, if you have hyperventilation pre-apnea, you hold your breath for so much longer, and it's the length of the breath hold time, that long breath hold time, which will be sufficient to lower blood oxygen saturation. So I think we have to consider that with mouth breathing, breathing is unstable. And this would point out that the individuals have higher loop gain. It's not just enough, of course, to get the mouth closed. We also have to consider the connection between the biomechanics of breathing and the stiffness of the throat. And this was a paper that was published back in 2014, published in The Lancet. And I'm not sure if I put it up so quickly now, but I'll see. And in terms of then, when you look at, if you increase lung volume, it increases, if you breathe more using the diaphragm, which will in turn increase lung volume, that the throat is less likely to collapse. So we have to consider the impact of nasal breathing on improved amplitude of the diaphragm. We know that when we breathe through the mouth, that it activates typically the upper chest. So what I'm going to just do is, one second, I'm just looking for the paper here and I've just picked it up. And I'll show you this reference here. This is a paper published back in 2014. Lung volume might also be caused a factor. In animals and man, the cross-sectional area of the upper airway increases when lung volume increases. Conversely, the airway is smaller and collapses more easily when lung volume is small. This relationship probably exists because the lower and upper airways are mechanically linked, so that with increased lung volumes, the structures are pulled, resulting in stiffening and dilation of the pharyngeal airway. This is very important. And the other aspect is increased lung volume also probably stabilizes the respiratory control system by increasing the stores of O2 and CO2. So with this, then we have to consider that it's not just enough to breathe through your nose, but we also need to train breathing in terms of functional breathing with greater amplitude of the diaphragm. Now, the third aspect that I want to look at is Messino's paper. And this is where I pointed out in terms of loop gain. So the whole field of sleep medicine has changed quite dramatically in the last 5 years. And Messino's paper looks at using breath hold time as a measurement of loop gain. So many of you with the AAMS, you will be familiar with this paper. He spoke in Rome about it. And the title of the paper is Breath Hold as a Means to Estimate the Loop Gain Contribution to Obstructive Sleep Apnea. Now, the interesting thing about this is that 30% of the adult OSA population have high loop gain. And the other thing to consider about this is that they don't respond to anatomical interventions. And the importance of tailoring the treatment to the individual phenotypes of the person is that the success outcomes are likely to be improved if you can tailor the treatment to the phenotypes of the individual. So the results here are that higher loop gain during sleep was associated with a shorter maximum breath hold duration and a larger ventilatory response to 20-second breath holds during wakefulness. So, for example, a high loop gain helps to predict a favorable response to non-anatomical interventions and an unfavorable response to anatomical interventions, for example, oral appliances or surgery. So if you have somebody that's wearing a mandibular advancement device, and if the patient isn't making good progress, it would be very interesting to measure their breath hold time. And if their breath hold time is low, it's very important to look and to address this. How do you improve or lower high loop gain? You simply do it by improving the chemosensitivity of the body or reducing the chemosensitivity of the body to carbon dioxide. So individuals with a low breath hold time during wakefulness is translating into higher loop gain during sleep. This may also be part of the reason that individuals with asthma, who typically breathe harder and faster, and because of the bronchoconstriction in the airways, that in turn is reducing their breath hold time. And the problem here is that when they stop breathing during sleep, that as they stop breathing and carbon dioxide accumulates in the blood during the stopping of the breath, when they resume breathing with such exaggerated ventilation that they go from high carbon dioxide to too low carbon dioxide. The brain then doesn't send the signal to breathe. This can initiate a central apnea, which is when the brain doesn't send a signal to breathe. But when the brain doesn't send the signal to breathe, the messaging from the brain, the output from the brain to the upper airway dilator muscles is also reduced. So my point with the phenotypes, and that's what I want to bring you, that they're all actually interlinked. And there has never been any research in looking at the application of functional breathing in terms of all aspects of functional breathing. It's not just enough to breathe through the nose. It's not just enough to measure the chemosensitivity of the body to carbon dioxide. We need some research that you get a group of people who have sleep apnea and teach them breathe light, teach them breathe slow, and teach them breathe deep. The next thing that I want to show you then is this phenotypes of sleep apnea, and just quickly show you the relationship between breathing and explain breathing and the phenotypes of sleep apnea. So the first phenotype of sleep apnea is the pharyngeal critical closing pressure. Hopefully you can see that. And this is the suction pressure at which the airway collapses. You don't want your airway collapsing at a low suction pressure. You want your airway to be able to withstand the pressure. And basically the pressure here we're talking about is the negative pressure created as air is drawn into the lungs. Now, flow is going to play a role here, because if you have your individual breathing lighter and slower, there's less negative pressure. And the other thing here is that peak rate is an anatomical measure. How can we help to open up the airway? Well, we know that the airway is smaller. Even with that last paper that we looked at that was published in Laryngoscope, when the mouth is open, the tongue is not able to rest in the roof of the mouth. And when the tongue is not resting in the roof of the mouth, the tongue is more likely to encroach on the airway. Maybe that's a simplified version, but also we have to consider that when the mouth is open, the mandible is also falling back and the throat may be more liable to collapse. Mouth breathing also then is activating upper chest breathing, and upper chest breathing then in turn is reducing lung volume, and as a result, the throat is more liable to collapse. So I think definitely, yes?
Just if you would be able to just describe loop gain so everyone's kind of on the same page.
Yeah, I will. So I'll come back to, I'm going through them now, so I am actually. I might even do it better from the manual. I'll just pull it up in a manual. So basically loop gain refers to how stable is your breathing during sleep. You see in this example here, you have the person, they are breathing hard. Do you see a diagram with waves there in terms of the breath? You have the person breathing hard, and they have a low breath hold time. And then they stop breathing due to collapse of the upper airways. But as they stop breathing, carbon dioxide is going to increase in the blood because it cannot leave the blood through the lungs because they've stopped breathing. But the problem with this is that people with high loop gain have an exaggerated ventilatory response to minimal changes of carbon dioxide. Now, during the stopping of the breath, carbon dioxide increases, but the real problem is when they resume breathing, how hard do they breathe? And those with high loop gain, when they resume breathing with very strong breaths, hard breaths, strong ventilation. And the problem with this is their catch-up breathing, it causes carbon dioxide levels to drop from being high to too low. Now, when CO2 in the blood goes too low, the brain then doesn't send the signal to breathe. And this then can initiate a central apnea. And the other aspect of it as well, published in that paper in The Lancet, which we looked at, the activity of the upper airway dilator muscles. So we have a group of muscles in the throat, and it's their job to help keep the airway open. The activity of the upper airway dilator muscles, it varies accordingly. So periods of low central respiratory drive, when the brain isn't sending the signal to breathe, are associated with low upper airway dilator muscle activity, high airway resistance, and a predisposition to airway collapse. So high loop gain also feeds into the phenotype called upper airway recruitment. But everything is interlinked. This here is Messino's paper. Thus, high loop gain contributes to perpetuating apnea. So it's like a vicious circle. The person stops breathing. When they resume ventilation, they breathe so hard, they blow off so much carbon dioxide from the blood through the lungs, and as a result then it initiates not only a central apnea, but the output from the brain to the upper airway dilator muscles is reduced, that it feeds into an obstructive event as well. So coming back just to do a summary of all four, and then kind of tying in, I think it's, it's been tremendous to see a recognition that sleep apnea is not just an anatomical issue. And breathing, we spoke about flow in terms of peak rate, and I'm just going to do a share on this one here. So we said reduce the flow, you're reducing the negative pressure in the upper airway, help to improve the anatomy of the upper airway with the mouth closed, with nasal breathing, with the tongue resting in the correct resting posture. Breathing is also through the nose with greater amplitude of the diaphragm, and with greater amplitude of the diaphragm, it increases lung volume, the throat is less likely to collapse. Loop gain is number 2. It's the stability of the ventilator, chemoreflex feedback control. In very simple terms, it basically means that the person with high loop gain has a low breath hold time, and when they have high loop gain, they have exaggerated ventilation to minimal increases to CO2. This is causing unstable breathing, which is feeding into the next apneas. Now, number 3 is very interesting because of all of the phenotypes of sleep apnea, in one recent paper that was published by, I think it's the American Journal of Respiratory and Critical Care Medicine, the phenotype which caused the greatest risk of mortality was arousal threshold. And arousal threshold basically means that individuals, they're either very deep sleepers or they're very, very light sleepers. So arousal threshold is the propensity to wake from sleep. How easy is it for you to awake from sleep? Now, what I'm going to do is just to show a different paper here, a little bit more detail on arousal threshold. Individuals with low arousal threshold, these people are light sleepers. And the problem here is that they wake up from the slightest negative pressure in the upper airways or the slightest change in the chemistry of the blood as a result of a resistance to breathing. And the problem is that they have continuous sleep fragmentation. So arousal threshold continuous unnecessary arousals can worsen obstructive sleep apnea, and it contributes to obstructive sleep apnea pathophysiology. But here is where I would like to bring in breathing. Stanford researchers, they identified a new structure in the brain back, as I said, in 2017. And they surmised that rather than regulating breathing, these neurons in the brain were spying on the breathing and reporting their findings to another structure in the brainstem. And they're reporting their findings to a structure called the locus coeruleus. But it's the locus coeruleus that sends projections to practically every part of the brain and drives arousal, waking us from sleep. So fast breathing can wake us from sleep. And individuals with fast breathing, we have to wonder, these individuals with fast breathing, are they more likely to have low arousal threshold? And this paper here seems to suggest it is. There is a relationship, of course, between insomnia and obstructive sleep apnea, to the point that, as I said earlier on, that one paper showed that 67% of people with obstructive sleep apnea have insomnia. And you have then an individual waking up tired in the morning, but why are they waking up tired? Is it because of the sleep apnea, or is it because of the insomnia, or is it because of the interplay of both? Slow breathing, nasal breathing, and diaphragmatic breathing helps to play a role in insomnia. The fourth phenotype in sleep apnea is upper airway recruitment. And this is the phenotype that myofunctional therapy plays a significant role. So there's 20 muscles in the upper airway involved in respiratory and non-respiratory tasks. And it's a subset of these muscles that play a predominant role in stabilization of the airway or helping to maintain an open airway. So myofunctional therapy has been shown to reduce the AHI index, and I think it's in mild to moderate sleep apnea, by 50%. And it will be focused very much on upper airway recruitment. 30% of people in the obstructive sleep apnea population have poor upper airway recruitment. Now, breathing also plays a role here, because we spoke about, for example, nitric oxide. And nitric oxide also is an aerocrine messenger. So with this study here, strategies to improve pharyngeal muscle function include regular didgeridoo playing and myofunctional therapy exercises. So I think you'll be more inclined to learn myofunctional therapy than to learn the didgeridoo. And the results from this is that it reduces snoring and obstructive sleep apnea by 50%. And those are the papers on that. So the other aspect then in terms of, and I don't have it on this, is with upper airway recruitment, nitric oxide from the nose seems to play a role as an aerocrine messenger to the upper airway dilator muscles, and carbon dioxide also plays a role. So for sleep apnea, it's really important to address breathing from a number of different dimensions. And what I want to do is I just want to open up one slide here just to show. So what would we encourage in terms of somebody coming in with obstructive sleep apnea? It's not enough just to get the mouth closed during sleep. However, it's a great start. So the exercises with obstructive sleep apnea is going to be nasal breathing both day and night. I will show you the tape that we use ourselves. It's Myo tape. We also use a tape called lip seal tape by Dr. Frank Seaman. And for years, we were using a tape called 3M 1-inch micropore tape. So we kind of go through the different options there. Also, having the tongue in the correct resting posture in the roof of the mouth is very important. And it can only be when we breathe through the nose that we can help to maintain the tongue in the roof of the mouth. If you have your mouth open and if you breathe through your mouth, can you have your tongue resting in the roof of the mouth? And you will see that it's pretty difficult. So pretty much all mouth breathers are going to have a low tongue resting posture. And the tongue has got two places to be. It's either in the roof of the mouth or it may be falling into the throat. And of course, if your tongue is falling into the airway, it's reducing airway size. It's very important for sleep apnea, but also for insomnia and snoring, to practice slow breathing with air hunger for 15 minutes before sleep, because this will help to result in a deeper sleep. But it's not just enough to practice slow breathing with air hunger for 15 minutes before sleep. You also need to practice it during the day. And typically I would have students coming in, of course not now, we're doing it all virtual, but 10 minutes by 3 times daily. So in other words, we're trying to get in about 45 minutes a day of slow breathing with air hunger. And this is to increase the breath hold time, to increase control pause, to increase Bolt score. Now, not only are we wanting to get slow breathing with air hunger, but we also practice diaphragmatic breathing. So the air hunger is helping to reduce high loop gain, and 30% of people with sleep apnea have high loop gain. The air hunger is also helping to reduce flow so that there's less negative pressure created up in the upper airway. And as less negative pressure, there's less turbulence, so the airway is less likely to collapse. But we also teach diaphragmatic breathing, and breathing with greater amplitude of the diaphragm, breathing in gently, slow breathing to a cadence of, say, 6 breaths per minute. So slow breathing and diaphragmatic breathing, because of the connection between the diaphragm and the upper airway dilator muscles, by increasing and causing a stiffening of the throat. But not only is slow breathing and diaphragmatic breathing helping to, the body with sleep, but it's also increasing the sensitivity of the baroreceptors. And with this, then we can influence the autonomic nervous system. So coming back to, if you were to do a sleep study, what would we typically suggest? Well, during a sleep study, it's also very important that when people are doing breathing re-education with myofunctional therapy, that they implement the same procedures as how they should be during, for example, during their normal sleep. So attending a sleep study, I would only say to students to go back for a follow-up sleep study only when your control pause is at least 20 seconds for 2 to 3 weeks. Because by then we know that breathing is starting to become more functional. And ideally it would be 25 seconds. That when the individual is habitually breathing knows when they are breathing slow and when they are breathing low. When they have habitual correct tongue resting posture. In other words, we should always wake up with the tongue resting in the roof of the mouth. And any apologies to any of the females present, but for men, they should wake up with not only the tongue resting in the roof of the mouth, but they should also wake up with an erection. And if they don't, it could be a sign that there is an issue with the heart. So during the sleep study itself, it's very important that while you're doing the sleep study, is to slow down your breathing with air hunger for 20 minutes before you go to sleep. But make sure that you tape your mouth. So either use lip seal tape or use myo tape. Now, because there's no point in going in for a follow-up sleep study and you're there lying on your back with your mouth open, with your tongue falling into the throat, and you wake up after the sleep study and lo and behold, here's a new CPAP machine for you. Off you go, bye-bye. Great stuff. So it would have been a waste of time. Now, I understand with myofunctional therapy, it can be advantageous to sleep in the back. The only issue I might say is that 50% of people with obstructive sleep apnea, their sleep apnea doubles when they lie on their back. We have to consider gravity. Now, and I can understand as well, if you see the shape of my face, and the left-hand side of my face, because I've been sleeping on my left side for many years, is actually flatter than the right-hand side of my face. So myofunctional therapy has been correct. I've learned it the hard way. The myo tape that I wish to show you, and I don't have Frank Seaman's tape, but I see Frank there. So if you have a sample to hand, Frank, to do a demonstration. But the one tape that I'm just going to show you is this as an option. And I think if one was doing a sleep study, it might be a little bit better perceived. And the tape is as follows. It comes in a pack of strips like this. And you tear off, it's just cotton tape with adhesive, but it's elasticated. And it's when I stretch it to about, it's well to cover the mouth, and obviously that didn't work. So you see now that there's an elastication by the tape, which is bringing the lips in together. And it's bringing the lips in together that it's ensuring nasal breathing, but we're not covering the mouth. And I think that's important for people who are apprehensive or people who may be doing a sleep study, etc. Now, we developed it originally for children. So because how could we get children? We were using tape, trying different ways of getting children to breathe through the nose. And yeah, it was working with mixed success, but that's why the Myo tape came in. The 3M 1-inch micropore tape is also very important. Now, in terms of COVID, a recent article that was published was, and hopefully I can pull this up here. So 1 second. And it spoke about the importance of nasal nitric oxide. And it also spoke about the anecdotal evidence in terms of breathing through the nose, in that it helped to reduce viral load, to give the immune system enough time to launch an adequate defense against COVID. So this was published by Elsevier, and this was published just about a month or two ago. And the title of the article is, Could nasal nitric oxide help to mitigate the severity of COVID-19? So it goes through in terms of nasal nitric oxide as being antiviral, antibacterial. And for example, here it talks about nasal breathing, filtering, warming, humidifying effects. You're harnessing nasal nitric oxide in the airways. Also, if you hum, it can increase nitric oxide production in the nose 15-fold. Nitric oxide in the airways assists with cilia movement, which is part of our defense, mucus production, antimicrobial effects, vasodilation, and bronchodilation. But it's the combination in terms of nitric oxide in the airways, which is reducing SARS-CoV viral load. Now, they spoke in the same paper about breathing through the nose during sleep. And by breathing through the nose during sleep, it was their evidence. And our anecdotal observations also suggest that favoring nasal breathing during sleep by sealing the mouth with adhesive tape reduces common colds. This phenomenon may be due to the filtration and humidifying effects of the nose on inhaled air, and to increase nasal nitric oxide levels in the airways, which may decrease viral load during sleep and allow the immune system more time to mount an effective antiviral response. Conversely, following viral infection of the airway epithelial cells, constant or intermittent mouth breathing in daytime and during sleep may reduce the beneficial effects of the nose and nitric oxide against the virus, therefore leading to unobstructed viral replication. Mouth breathing during sleep may therefore worsen the symptoms of COVID-19, consistent with the observation that the symptoms of respiratory infections are usually worse in the morning. Now, we've been speaking about this for months, but it was tremendous for somebody that they put an article that has been published on it. And there you see the title of the paper. So I know there's going to be some questions, and I covered pretty much the main topics that I want to cover. We spoke about the different breathing exercises, both during rest, during physical exercise, the importance of nasal breathing during sleep. With children, the exercises are pretty much the same, but we involve more physical exercise. But we do encourage children to wear tape on their lips during the day. And I used to get very frustrated with children because we'd have kids coming in. I would do all of the breathing exercises with them. Off they go. And a week later, they come back and the mouth is hanging open. I knew they could breathe through the nose. And I knew that the exercises were helping to decongest the nose. But our issue was, how do we change the behavior? And it was only by we introduced taping during the day, especially when the child was distracted, starting off at 30 minutes a day for the first week or so, then to 45 minutes. And with that, then that was helping to change the behavior. So one benefit, you could use tape across the lips of a child during wakefulness. However, it is not well perceived if you encourage children to wear tape across their lips during sleep. And we have had some dentists, unfortunately, a couple of our instructors who have had to respond to questions with regards to taping of the mouth, covering the mouth during sleep. So I think an option would be is to tape surrounding the mouth to bring the lips together. And also during wakefulness for kids, because the tape was developed for children, in terms of children can wear the tape, but they can still talk. And if the child forgets about breathing through the nose and opens the mouth, the tape will automatically remind them to get lip closure again. So there's a repeated messaging there. Okay. So we were talking about female breathing too. And I think it's really, really vitally important to realize that young females, post-ovulation, days 10 to days 22 during the luteal phase, that their breathing is naturally going to reduce due to the increase of progesterone. But if we had females with a higher Bolt score or control pause normally, that they would be in a better position in terms of symptoms. And it could be possible that many of the symptoms that they are experiencing PMS is actually due to the changes of their breathing patterns. So we've only had reported, in the last, and we've only been putting it out there for a very short period of time, that females, when they are practicing the reduced breathing, that they are better able to deal with the symptoms of PMS. I think it's vitally important to recognize that the female population are more prone to breathing pattern disorders. That also can play a role, as I said, with increased pain, talking about temporomandibular joint pain, etc., which can be more common in females, and fibromyalgia, which can be more common in females, and rheumatoid arthritis. And I'm not saying that breathing is the cure of these, but what I am saying is that it can be a help. Okay, so I'm just going to see if there's any questions that you have.
Some people have been asking a little bit about first of all, where you can get myotape and 3M micropore. I did let them know, but.
Thanks, Samantha. The myotape is from myotape.com, and myo is in myofunctional therapy. And lip seal tape is lipsealtape.com, but I think, Frank, you've changed your website to Simply Breathe or Breathe Simply. So maybe.
Yes, we have.
And what is it? breathesimply.com.
It's now Simply Breathe.
Simplybreathe.com. So Frank's tape we used for many years, which is very, very good. It's a very nice cotton tape. It's very pleasant on the skin. And it's a good tape. 3M micropore tape you can pick up in pretty much any drugstore. You can pick it up on Amazon. It's cheap. As I was saying, just with kids, make your decision on that. But adults who are apprehensive, sometimes they don't feel comfortable with taping. I'm just saying, what is air hunger? Air hunger is pretty much the feeling that you're not getting enough air. So when you're practicing the breathing exercises and you're gently slowing down and reducing breathing volume, the objective is that you feel air hunger. So the air hunger means that it's just because of, if you breathe a little bit less, carbon dioxide doesn't leave the blood so quickly through the lungs because you've reduced the volume of air that you've breathed. And as carbon dioxide increases in the blood, the body is very sensitive to an increase of CO2. So a very minute increase of carbon dioxide, for example, between 2 and 5 millimeters of mercury, that can double ventilation. But we want to expose the body to higher CO2 because it's on that basis that we help to reduce the chemosensitivity of the body to carbon dioxide. And that's very important to improve functional breathing, to increase the control pause, to increase the Bolt score for people with low Bolt score or low control pause for sleep apnea disorder. Because if you think of, in panic, there are two groups, and one group is very sensitive to carbon dioxide. They have a very strong suffocation reaction, and that can bring them into a panic. So what we want to do is a little teaspoon of suffocation to desensitize them to that feeling so that it's not feeding into a cycle. I'm just going to get that link in terms of the nitric oxide paper. It's a very, very nice read, and it feeds well into what we've been talking about. So that should have come up there, that link there. If you click on it, you should see Elsevier. So some question, how often to practice the 5 second in and 5 second out for lowering blood pressure? Typically, the studies show that you would want to be doing it for 20 minutes twice daily. And you can't go wrong with 6 breaths per minute. So that would be 5 seconds in and 5 seconds out. And when you practice that exercise, do it in and out through your nose, but also do it with lateral expansion and contraction of the lower ribs. I would suggest that you do it while watching TV. Now, as you practice it, you will see, likely, that your blood pressure will lower even as you practice it. So the sensitivity of the baroreceptors play a very important role in the management of blood pressure. And, you know, with high blood pressure or with low blood pressure, when you increase the sensitivity of the baroreceptors, you can help to normalize your blood pressure. And when practice then with your doctor is to ask your doctor to regulate or to alter your medication to suit you. So the baroreceptors, these are the pressure receptors in the major blood vessels, in the aorta, and also in the carotid arteries. And there's a very good article that was written by an author called Mark Russo called Breathe or Slow Breathing. And he goes through the application of slow breathing across many health issues. And it's an okay read. It's not full of jargon, so it's easy enough to understand it. How do you feel about putting the 3M tape vertically so the whole mouth is not covered? Yeah, like we've been using 3M micropore tape for 20 years. You know, so we like in terms of bringing out the myotype, we just felt that people can get a little bit scared, and, you know, healthcare professionals as well, it could raise a couple of eyebrows asking patients to tape across their mouth. Like, fortunately, we've never seen any issues wearing the taping. And if you think that we've probably, I don't know how many tens of thousands of copies of the book have gone out there. Certainly it's gone into the hundreds of thousands, because I know I've one copy, Close Your Mouth. I've done 11 print runs on it, and typically I'll do a 10,000 print run. So touch wood, we haven't seen that, but at the same time, I wanted to minimize risk. So that's what we did that. So what posture you recommend for those who start practicing the breathing exercise? You could do it sitting, or you could do it lying down. It's whatever's comfortable. And it's really about, you know, it's not just about counting the breaths. You know, counting the breaths is only looking at one pattern of breathing. We need to look at breathing from biochemical, biomechanical, and coherent breathing. If we just focus on breathing in for 5 seconds and out for 5 seconds, it's not necessarily the whole thing. And I'm not here just to complicate it, but there can be a mistake by counting breathing in terms of time, because you also need to consider the volume of air that you take in that period of time. And we've seen examples that were in psychotherapy, patients who were breathing too fast. They had 20 breaths per minute, and we'll say the tidal volume was a half a liter, giving a minute ventilation of 10 liters. When the psychotherapist asked the client to slow down their breathing, the client slowed down the respiratory rate to 10 breaths per minute, but in the process, the tidal volume increased disproportionately, so that minute ventilation increased, and that caused chronic hyperventilation. So we always think of breathing as that balance: light, slow, deep. And inhale 1, hold for 4, exhale 2, hold 2. It would be a good exercise in terms of, it's a little bit like box breathing. So that could be a ratio of 4, 4, 4, 4. Inhale 4, hold 4, out 4, hold 4. And it will help to get a little bit of, you know, in terms of stress management, that exercise would help. So when you have typically a longer exhalation, you're helping to activate the body's parasympathetic response. And if you have a light air hunger during it, you're also helping with the biochemistry. So you need to pace yourself that you never mouth breathe. Slow down your pace so that when you feel, you can amp it up. Yeah, like I think any of these exercises, you know, any exercise that you find difficult to do, if the cadence isn't right, typically lower the cadence. So if 5 seconds in and 5 seconds out is too difficult for you, do 3 seconds in and 3 seconds out, and practice just gentle and slow lateral expansion and contraction of the lower ribs. And then with practice, you gently build it up. Suppose, you know, we need to crawl before we walk and we walk before we run. So we just gently do it. And that was often the mistake that I had with students. I'd be too kind of eager to give them breathing exercises, and sometimes I put them into anxiety. And with people coming in with chronic fatigue, I floored them. And the people with chronic fatigue wouldn't come back to me. So that wasn't an ideal solution. So I've learned many things. And I've also realized that breathing, it's very important to tailor breathing to the individual to get a better outcome. And that comes with experience. And I would say, like, for any of you, pay attention to your breath. I know many of you are breathing instructors anyway, but just even focusing on your breathing and taking attention out of the mind onto the breath, it helps to bring a gap between thoughts, and it helps. It's very calming, and there's so many benefits in terms of sleep, anxiety, exercise, influencing the autonomic nervous system. And I have no idea how people get through life, you know, with the stresses and the grinds of daily life without having some resort to breathing, because breathing is that constant in your life that you can connect with. It's always there. Regardless of what's happening on the outside, you can always bring your attention inwards. And it's not about taking that full big breath. It's always about having an understanding. The best teacher in terms of breathing is a cat. The best teacher in terms of breathing might be an infant baby. You know, they have nasal breathing, they have regular breathing, they have diaphragmatic breathing. They're not intentionally taking big breaths. And the young infant baby is typically breathing in and out through your nose. Humming can be very helpful in terms of the emptying of nitric oxide from the paranasal sinuses into the nasal cavity. And when you hum, you want to be humming in a way that you feel the vibrations of the roof of the mouth. So you want to feel that your nose is literally vibrating. So you're taking a breath in, and then you're humming over a prolonged period of time. And then after the end of the hum, breathe in through your nose. So the nitric oxide that is accumulated in the nose at the end of the humming, you want to carry that air into the lungs. And nitric oxide from the nose is isolated to the lungs, but it has a huge role to play. You know, first identified in the human breath in 1991, and probably still being uncovered, the exact functions of nitric oxide. But it is accepted that it does help to redistribute the blood throughout the lungs. It helps with gas exchange. It helps with opening up the airways. And it's generally accepted that nitric oxide plays a role in the sterilization of incoming air. So I just want to see if there's any more. I think that's about it. So what I would say is, thanks very much for sitting in. And we got through what we wanted to get through, and kind of timing sometimes can be a bit of a, you know, hit and miss, especially with me, but yeah, we're fine. I'd like to say thanks very much to Samantha for organizing with the AAMS. It's been absolutely tremendous, the work of the AAMS and Mark and Samantha and Joy over the years in terms of putting breathwork and nasal breathing out there. We have some way to go, but we are really making inroads. I think something is starting to happen now. Never before has there been a better awareness, and I only know that judging by the amount and the volume of emails that I come in. Now it's got to the point that sometimes the volume of emails is completely impossible for me to get through, and that has happened this year. And so something is definitely happening, which is great. So I'm going to pass you back to Samantha.
Patrick, thank you so much.
Sure.
It's really wonderful to be able to share the information, and people who are not clinicians to be able to sit in and listen to this. It's really part of what we are seeing as this next stage of getting the messages and people getting more aware of their own breathing and their own health conditions, which is such a relevant and pertinent issue today with COVID. And, you know, the work of others who have been able to bring this message forward. James Nestor certainly is getting this message out there, but you also have been doing this as a clinician, trainer, educator, prolific writer. And so it's really been wonderful to be able to share this. Thank you for your time. And anyone else who has questions, you can always go into the Facebook Congress group, ask questions, or the Facebook page, and someone will get back to you. Anyway, that will conclude our session today. Thank you all, and wonderful to see you here. Bye.
Thank you, Samantha.